The adjustable gastric band is an inflatable napkin ring-like device that's implanted into the very top part of the stomach. The degree of inflation can be controlled by instilling fluid through a port that's implanted underneath the skin onto the muscle, typically in the left upper abdomen. As fluid is placed into this band, it pinches off the top part of your stomach, allowing only small quantities of food to escape into the bottom stomach. This is what brings about satiety and weight loss. There are several types of bands available today. They all have in common a fixed diameter outer shell and an inflatable component within this shell. By controlling the amount of fluid within this inflatable component, we can adjust the amount of restriction that a person experiences, thereby controlling the weight loss. The process of instilling fluid through the port is called a band adjustment. We typically do the first adjustment 6 weeks after surgery. It's a simple office procedure that takes about 15 to 20 minutes. Most patients need about half a dozen adjustments to achieve the right amount of restriction for progressive weight loss. The goal of an adjustment is to bring about early and prolonged satiety and a sense of fullness with small quantities of food. This is referred to as the green zone. It's important that we don't overshoot this point and instill too much fluid, as this could prove detrimental to the esophagus by bringing about swallowing difficulty, heartburn and reflux, which in turn could translate to poor eating behavior, which may actually result in poor weight loss. The proximal Roux-en-Y gastric bypass is the most commonly performed weight loss operation in this country. The word Roux-en-Y means fork in the road in French. In this operation, we are creating a fork in the road between the path that the food takes from the path that the digestive juices take. A small, roughly half an ounce stomach pouch is created by dividing the stomach vertically. This pouch is then connected directly to the intestine, which is rerouted so that the food stream bypasses the stomach, duodenum, and upper intestine. The digestive juices are diverted from the food stream by about 5 feet, or roughly 1/4 of the upper small intestinal length, thereby bringing about a mild reduction in calorie absorption. Since only a small amount of intestine is bypassed, the risk of malnutrition is minimal. Most patients report feeling full after eating about 2 ounces of solid food. In this type of operation, neither the stomach nor any of the intestines is removed. The pouch that is created for a medial gastric bypass is similar to the one created in the proximal gastric bypass. Again, this pouch is connected directly to the intestine, which is rerouted so that the food stream bypasses the stomach, duodenum, and the upper 1/2 of the small intestine. The medial Roux-en-Y gastric bypass is different from the proximal gastric bypass in that roughly 2/3 to 3/4 of the upper small intestinal length is bypassed. It works not only by inducing a sense of fullness or satiety with small amounts of food, but by also significantly reducing calorie absorption. Again, in this type of operation, neither the stomach nor any of the intestine is removed. The last 1/3 to 1/4 of the total small intestinal length, where the food stream and the digestive juices mix together, is where absorption occurs. And this is called the common channel. Absorption of nutrients and calories is determined by the common channel. The shorter the common channel length, the less the risk for weight regain by decreasing calorie absorption. The longer the common channel length, the less the risk for nutritional problems. The common channel length varies from 5 to 7 feet. The duodenal switch is unique among all weight loss surgeries in that it enables patients to eat a near normal meal by preserving 20% of the non-stretchable inner portion of the stomach. The operation works primarily by decreasing calorie absorption by bypassing roughly 2/3 to 3/4 of the upper small intestinal length. The outer stretchable 80% of the stomach is removed, leaving a tube-like stomach with roughly 150 ml or 6-ounce capacity, so patients generally feel full after eating a 4 to 6 ounce solid food. The duodenum, which is the first section of the small intestine, is divided and connected to the last 10 to 12 feet of small intestine. The top half of the intestine carries just the digestive juices and is called the biliopancreatic limb of the intestine. This is connected to the food stream 3.5 to 7 feet from the large intestine. Absorption of nutrients and calories is determined by the length of this last segment of intestine where the food and the digestive juices mix, and this is referred to as the common channel. A long common channel decreases the risk for nutritional problems. A short common channel decreases the risk for weight regain by decreasing the calorie absorption. Patients in this operation do not have the dumping syndrome when they consume sugars because the stomach valve or pylorus that regulates the exit of food from the stomach is preserved in this operation. The sleeve gastrectomy is a purely stomach restrictive type of surgery that is becoming very popular for control of morbid obesity. In this surgery, the upper and outer most stretchable part of the stomach is removed, thereby considerably decreasing the capacity of the stomach from about a quart to about 2 to 4 ounces. In other words, the stomach is converted from a bag to a pipe that's roughly the size of the ring finger, 6 inches long. Weight loss is achieved by restricting the quantity of food consumed and by significantly reducing appetite hormone or ghrelin production in the stomach. Patients generally report feeling full after eating 2 to 4 ounces of solid food. It preserves all the important structural elements of the stomach, such as the antrum, the pyloric valve, and the nerves that control stomach function, leaving a stomach that's much smaller, but one that is close to the normal stomach in terms of its function. It provides a fairly quick, predictable weight loss and allows patients to enjoy a wider variety of foods than would be typical for other weight loss surgeries. Among all the operations for weight loss, it is the most pill-friendly operation, so patients don't have to make major changes in their medications. Anti-inflammatory medications that are not generally recommended after weight loss surgeries are better tolerated with this operation than with any other operation. Unlike the adjustable gastric band, this operation does not require periodic adjustments. The stomach tube is created by placing a predetermined plastic tube along the inside part of the stomach, and this is used as a sizer to staple off and remove the rest of the stomach.